All right. Well, good morning, everyone. I hope everybody can hear me. If you're just logging in, feel free to go ahead and open up your chat box, say hello, change your chat box feature to everyone. Feel free to say hello and where you are logging in from. We have a record-breaking audience today, so this is going to be quite the review. If you have not yet followed me on Instagram or any social media platform, even TikTok, but feel free to put a picture on Instagram on your story of your study space and tag me at HyGuru Prep. I would love to feature you. You all really drive me to create these engaging reviews. We have a worldwide audience, which is super exciting. We're going to get started in just about 3 minutes. If you all can hear me and see me, do you mind going ahead and typing in yes into the chat box, please? Great. I hope everybody can see my slides as well. I'm getting a lot of yeses. This is great. And feel free to share the live stream link. You all are in the Zoom classroom, which is great. I am going to be doing a live question and answer session at the end of our session today. But we're going to get started in just about 2 minutes. Feel free to share your study space and tag me. Make sure you have a notebook out so you are able to take notes as we go through this rapid review. This session will be a little bit over an hour. We're going to get started in just about a minute or so. And if you're just joining, I saw a lot of students who have just joined right now. Feel free to say hello and where you're logging in from. Excellent. We have Kurt from Canada, Horvey from Dallas, Aaron from Nashville. Great. And if you're just joining, if you don't mind turning on your chat feature to everyone, that would be wonderful. There are going to be a lot of questions from for the chat box, excuse me. And so feel free to go ahead and turn it to everyone so we can all see our responses. All right. If you have not yet just followed me on Instagram or subscribed to my YouTube channel, feel free. I also am active on TikTok, so more than welcome to follow me, and we're going to get started in just about a minute or so. All right. Excellent. A lot of people joining. Great. Well, thank you all so much for joining. Let's go ahead and get started with our review today. If you are just joining, feel free to say hello in the chat box, turn your chat box to everyone. Make sure you have something to write with or a blank notes tab open, because this is going to be a high yield internal medicine review. I want to personally welcome you all to the top NBME shelf concepts review for internal medicine. Remember, internal medicine is about 60% of your USMLE Step 2 CK. So this review today is going to be jam-packed with the highest yield material. I'm going to start out with a little bit of an introduction. This review is going to be perfect if you're gearing up for the internal medicine shelf, the CCSE or comp exams, or you are looking for the extra point boost on your USMLE Step 2 CK. I guarantee you that the concepts that we will cover in an integrated manner are going to be exquisitely high yield for you on exam day when you walk into that Prometric Center. My goal is to make you feel prepared. My goal over this next hour and a half is to make things a little bit more fun and less painful than doing questions by yourself. So I'm grateful that we have over 400 people here today. No pressure, Rahul. You got this. All right. Very good. Well, if this is your first time logging into my webinars or watching this YouTube video, I just want to say hello and introduce myself. My name is Rahul Damania. I am a pediatric critical care physician. I am newly minted a associate clerkship director for the pediatric clerkship. So I'm super excited about taking on this role. Just last year, I graduated with my master's in medical education. And what wakes me up every single morning is helping students just like you prepare for and excel on the USMLE Step 1 and Step 2 CK. My website, HyGuru.com, is there for your liking, and feel free to connect with me on there, and you can see some of my courses and some of my social media platforms on there as well. I know many of you have looked at my Step 1 playlist. That is a growing playlist on YouTube. Just by show of hands in the chat box, how many of you all have watched my content for USMLE Step 1? All right. We got a lot of people saying yes. Excellent. Well, what I have resolved to do over the past year or so is grow my content for Step 2 as well. And my hope is that whether you're preparing for Step 1, shelf, or Step 2, you have a series of high yield, impactful reviews that will give you a great overview, not only as to how I teach, but overview of the highest yield material that you're going to see on exam day. So I want to spend just a few minutes telling you why I think HyGuru is so unique, what differentiates it. With HyGuru, I have centered myself on being strategic and focused on active learning. Many of the questions you'll see today are going to be vignette focused. We are going to be linking amongst many organ systems. I'm going to make a link from derm all the way to oncology. We're going to be focused on test-taking strategy because a strategic approach on exam day is going to help you overcome that feeling of getting down to 2 and picking the wrong one. And finally, as you can see from my energy today emanating through your camera and into your study space, I focus a lot on the mental grind, the test-taking psychology. The dedicated study process is full of ups and downs, but my hope is that you don't lose enthusiasm and you take each day, each incorrect as a learning opportunity. So this is the triad of USMLE Step 2 preparation that I focus on when I'm preparing students one-on-one and especially in my courses. I focus a lot on content integration and clinical reasoning. Specifically, I break down a vignette similar to how you would on your clerkships or as a physician. Test-taking psychology, we mentioned how it's all about staying positive, staying sharp, and practicing like you play, and being productive on a day-to-day basis, making sure that you have a systematic way of reviewing UWorld blocks or NBME explanations. How do you take notes, etc. One of the things that I'm also increasingly fascinated about is the role of artificial intelligence in how we can best prepare for USMLE. And if you all feel like this is a topic you want me to cover on my YouTube channel, feel free to go ahead and comment yes, and I'd be more than happy to make some content surrounding this. Most importantly, and we see this with over 400 people joining today, HyGuru is a lifelong global community of students who are aspiring to be the best physicians ever. My goal is to not just focus on the 3-digit score, but inspire you to be on a lifelong learning journey. It is right around July 1st, which is when many residents across the country are starting their next phase of training, which is residency. And this is just a small snapshot of some of the HyGuru students this year who have passed and who have gone on to become just excellent physicians and residents, and I'm so proud of them. And it all started with this USMLE journey from step 1, step 2, and beyond, and want to just extend my congratulations to the HyGuru students. Now, this may be a unique infographic for you. And why I say that is because this is a traditional lecture. A traditional lecture is very linear in nature. It has a heading and it has some bullet points. And sometimes when you are going through some traditional resources, you are not only just getting the content, but at times you may be missing the application. And that's where HyGuru really focuses on making things very integrated, connected, making you feel like you're on the edge of your seat, testing yourself. Because when it comes to principles of adult learning theory, making sure that one tests themselves in an interleaved manner is going to help you retain and encode the material more effectively. With this vignette-based approach, I've been super grateful to have students over the past few years on Step 2 CK and Shelf do super well. And you being here today and spending this hour and a half or taking the time to watch this video really means so much to me. And I am hopeful that you will be on the same kick-ass score trajectory. Today is very special because I am going to be doing a quick live review and preview of my comprehensive USMLE Step 2 CK course. I'm going to spend a little bit of time at the end going through the features of the course. I'm going to put the course in the chat box so that you all have it. Feel free to sign up. This is going to be about an hour preview of the comprehensive material. The internal medicine content, just for reference, is about 12 hours in the USMLE Step 2 CK Rapid Review course. It also has questions and flashcards associated with it. So I hope that you take some time to just check it out and see if it's right for you. So I do want to take you backstage. And why I say that is I want to tell you a little bit about the process of how do I make my USMLE reviews. For me, my hope with HyGuru was to just isolate the highest yield content. I may not cover absolutely everything you need to know, but follow me with this thought process. If you get your accuracy of high yield material from 65% to 80% or 90% of the top 100 highest yield tested concepts, you're going to do so well on the USMLE Step 2 CK. And what I say is focus on the high yield first and then branch out into some of the esoteric questions. So to me, these popular resources right here serve as a little bit of a template for me. What are the questions and topics that are frequently being assessed? And whenever I notice that these topics are being repeated over and over again, my goal is to categorize that as high yield, write a vignette about it, go through the pathophysiology, in this case, highlight the diagnostic and therapeutic management, and deliver it in a high yield energetic review. So without further ado, I appreciate you all sticking with me through this introduction. I just want to have you all type into the chat box. Are you all ready to get started here? Go ahead and type in yes. All right, I'm seeing a lot of yeses. Thank you all so much for your participation. I just want to start with a disclaimer right here. In the age of digital distraction, the new currency here is focus. So what I would encourage you all to do, and this is so important, especially in this day and age, is take your phone, close any browser tabs that you are not using, and just create a tight bubble of focus with me for the next hour and a half. I would encourage you all to have something to write with or a notes document up so that then you can really stay locked in with me throughout this review. This is going to be a review session, so I am going to explain some concepts, but it is more designed to be that rapid review, synthesis-like review, and feel free at a later time to pause the video, come back to it, etc. So I appreciate you all just staying focused with me. I know that there are a lot of distractions. Sometimes there's just a lot of stress, but I promise you this is going to be time worth spending. All right, we're going to go ahead and get started with our first internal medicine slide. So what I'm going to do is I'm going to give you just a general patient vignette. And that is a patient presents with hypertension, diabetes, dyslipidemia, and smoking. Whenever I see that a patient has these risk factors, I say that they have a lot of atherosclerosis. Now, when they have atherosclerosis, they have narrowing of a artery, for example, and that can then cause end organ damage. So now what we're going to do is pair this atherosclerosis stigma to different vignettes. So let's go through this. Let's say the patient has reduced ankle brachial indices and pain in the buttocks while walking. What do you think the diagnosis is? Go ahead and type into the chat. We're going to get warmed up today. Excellent. If you're saying peripheral artery disease or the symptom of claudication, you're absolutely correct. Remember that classically on physical exam, they're going to have shiny extremities or hair loss, indicating that there's poor perfusion. What if you have chest pain and diaphoresis that is acute? Or let's say in an elderly female with atherosclerotic risk factors, there are these non-specific symptoms like lightheadedness and upper back pain. Excellent. If you're saying acute coronary syndrome, specifically myocardial infarction, you're absolutely correct. I do want to emphasize that in females, there could be some atypical presentations, and hence why I added this for comprehensiveness. Next vignette, atherosclerotic risk factors plus sudden onset dysarthria and unilateral weakness. If you're saying stroke, you're absolutely correct. Remember, a transient ischemic attack is going to be a focal neurological deficit that is typically going to resolve within an hour. One of the things for us to note that can tie into neurology is if a patient has recurrent strokes or TIAs and has atherosclerotic risk factors, they are going to be at risk for vascular dementia, which presents on your shelf in USMLE as stepwise cognitive decline. What I also want to emphasize here is anytime you see a focal neurological deficit, you must say the word stroke. Next best step in management is non-contrast head CT. That is going to help you stratify whether the stroke is going to be ischemic or hemorrhagic. All right, atherosclerotic risk factors plus hypertension plus a pulsatile abdominal mass and periumbilical bruit. Remember, the pulsatile abdominal mass is going to be indicative of an abdominal aortic aneurysm. Especially when you see a periumbilical bruit, you should be thinking of renal artery stenosis. In this case, the abdominal aortic aneurysm is pretty big, and so thus it is going to be compressing on the renal arteries, leading to RAS activation and the hypertension. For surgery, you do need to know that if you have an abdominal aortic aneurysm greater than 5.5 centimeters, you're going to be thinking of elective repair. And if this patient who has smoking and an abdominal aortic aneurysm has sudden hypotension, you should be thinking of hemorrhagic shock or an expansion of the abdominal aortic aneurysm leading to potential severe complication, which is rupture. All right, next vignette, atherosclerosis plus severe tearing back pain and unequal blood pressures. Excellent. If you're saying aortic dissection, you are absolutely correct. Remember, aortic dissection is one of your differentials for a widened mediastinum. You also have to integrate the pharmacology. The USMLE loves for you to know that aortic dissection, things like varices, there's this whole pathophysiologic concept of vascular strain. So if there is going to be increased vascular strain, a patient with aortic dissection is going to be at increased risk for rupture. Now, what is going to reduce vascular strain is going to be beta blockers. Remember that aortic dissection can be also seen in patients who have connective tissue disorders, such as Marfan's. Next one, atherosclerotic risk factors plus abdominal pain. The patient has this postprandial abdominal pain with weight loss. And if you're saying chronic mesenteric ischemia, you're absolutely correct. Think of this as an intestinal angina. The fact of the matter here is that your celiac, SMA, IMA, those are all going to have a lot of atherosclerosis. So when they eat, that increased blood flow through the atherosclerotic narrowings is going to cause you to have postprandial pain. All right, last one here. Atherosclerotic risk factors plus absent brachial pulses after combing hair, i.e. it is a positional pulse differential. And if you're saying subclavian steal syndrome, you're absolutely correct. Watch for the reversal of that vertebral flow, and you can even get reduced cerebral perfusion because of subclavian steal syndrome. All right, so this is a quick snapshot of how I teach. Are you all resonating with this, both in the chat box and on YouTube? Go ahead and type in yes into the chat box. All right, excellent. Let's go ahead and keep going with this high energy. So one area that I wanted to integrate, because on Shelf and Step 2CK, risk factor questions are very rampant. I want to just integrate right here smoking as a risk factor. Now, there are many conditions that are associated with smoking, and my goal with this slide is to highlight the highest yield ones. First, we're going to be thinking of smoking being associated with aneurysms, and those aneurysms can cause subarachnoid hemorrhage. Remember that thunderclap hyperacute headache. Smoking is also going to be a risk factor for squamous cell carcinoma of the head and neck. Watch for a patient who is going to have a mass or lymphadenopathy and a longstanding smoker. We also are going to be thinking of esophageal cancer that is associated with smoking. Remember that the esophageal cancer type of thought process is going to be because of chronic irritation. We talked a little bit about how smoking is going to cause you to have a vascular disruption. That vascular weakening can not only cause aneurysmal dilation in the brain, but also causing a AAA. Smoking is an important risk factor for renal cell carcinoma. Remember, renal cell carcinoma typically presents as flank pain plus hematuria. And smoking is going to be a risk factor for bladder cancer as well as pancreatic cancer. And here's a little riddle for you to integrate. Painless jaundice is to pancreatic cancer as painless hematuria is to bladder cancer. Next best step in management for pancreatic cancer is going to be getting a CT scan. And next best step in management for bladder cancer is to get a cystoscopy. Now, anytime you are going to see in your vignette, a patient has long-standing smoking history, typically they'll say greater than 20-pack year smoking history, or they'll say daily smoker for a prolonged period of time, you should be paying your respects to lung neoplasms. And in particular, under lung neoplasms, you should be thinking of paraneoplastic syndromes. Now, the general presentation for lung neoplasms is going to be chronic cough, hemoptysis, and weight loss in an elderly male smoker. The key here is to look for paraneoplastic syndromes and a centrally located endobronchial mass. Sometimes that centrally located mass can actually compress the airway and cause you to have recurrent pneumonia. Typically, for your diagnosis, you're going to be going from least invasive to most invasive. So you're going to be doing chest X-ray, then CT, and then a biopsy before you start treatment. So what I'm going to be highlighting now are, in this column, the paraneoplastic syndrome, the diagnosis, and then the tumor that it is associated with. Let's go through this. Seizures and hyponatremia. Go ahead and type into the chat, what is going to be the paraneoplastic syndrome here? Excellent. If you're saying SIADH, too many aquaporins in the collecting duct, you're absolutely correct. What about facial plethora and hyperglycemia? If you're saying Cushing syndrome, you're absolutely correct. Remember that Cushing syndrome, you are going to have a paraneoplastic ACTH secretion. What about weakness, dry mouth, and absent/diminished reflexes? So it's autonomic symptoms plus neuromuscular junction symptoms. You're thinking of Lambert-Eaton myasthenic syndrome. Remember, unlike myasthenia gravis, Lambert-Eaton is going to have muscle weakness that improves with repeated stimulation. I do want to turn your attention to the autonomic symptoms, such as weakness and dry mouth, that can occur. What is important for us to know is that whether you're talking about SIADH, Cushing's, or Lambert-Eaton myasthenic syndrome, they are all associated with small cell lung cancer. All right, so this is the mnemonic I call the C's: hypercalcemia, cavitary necrotic lung lesion, and an association with squamous cell carcinoma. You're going to be thinking of parathyroid-related peptide. Remember that PTHRP is kind of like parathyroid hormone, so it is going to cause you to have excessive amounts of calcium. So the take-home point from this slide is that if the social history states smoking, think about lung cancer or pay your respects to it in terms of your differential, and then think of the paraneoplastic presentations. Another way that I want to integrate your IM prep is to take a chief complaint and break it down based on the different vignette components. So let's say that a 50-year-old male presents with chest pain. What would be some of the symptomatologies that they would give you in the vignette if they wanted you to go more towards musculoskeletal? Well, if you're going to be thinking of pain that is going to be worse with palpation, a history of trauma, or even a upper respiratory tract infection in which the patient had a lot of coughing, you're going to be thinking of costochondritis. And remember that the management is going to be NSAIDs to reduce the inflammation. What if the patient has chest pain and the USMLE wanted you to be thinking of pleural or pericardial inflammation? Well, they're going to give you pain that is going to be worse on inspiration. At times, they may say that the pain is going to be positional. This is especially true for pericarditis, in which the pain is going to be worse when lying down, better when leaning forward, and you can have that characteristic friction rub. What is important for us to note is that with pericarditis, if you are going to have a lot of inflammation, that inflammation can cause you to have fluid in the pericardial space. And if that is going to accumulate, you can get pericardial tamponade as one of the feared complications of pericarditis. What if the patient has chest pain and the USMLE wants you to know that it's more valvular in nature? Well, this is where you're going to pay attention on the physical exam. You're going to be thinking of murmurs. Murmurs are going to be associated with turbulence. Remember that if they say that the patient is an elderly patient that is going to have a murmur best heard at the right second intercostal space, that crescendo decrescendo murmur is going to be characteristic of aortic stenosis. Remember, with aortic stenosis, you're going to get syncope, angina, and dyspnea, the classic SAD mnemonic. And syncope, the pathophysiologic mechanism there is that you get reduced cerebral perfusion. Now, what if they wanted the chest pain to be more towards ischemic in nature? Well, they're going to say the word exertional or worse with activity. They're also going to describe the pain as more squeezing rather than a sharp chest pain. Ischemic chest pain usually is going to be that squeezing, an elephant is sitting on my chest type of pain, and there's going to be associated diaphoresis. With acute coronary syndrome, you could be thinking of a whole spectrum. You could be thinking of unstable angina, myocardial infarction, which can be classified as STEMI or NSTEMI. What's high yield for us to know is that with unstable angina, you are going to have negative troponins, whereas with the myocardial infarction, you're going to have positive troponins. All right. So this is another way that I like to integrate pathophysiology. And what I'm going to be doing for this shelf review is put in the management and diagnostics right next to the pathophysiology. Because rather than memorizing, it's so important to understand the pathophysiology and how management therapeutics are going to modulate that pathophysiology. And I think that that can then transition you from just studying to actually learning and encoding. So let's go through this. Let's say you have a patient who has atherosclerotic risk factors that then creates a plaque in the coronary. And that causes a near complete thrombotic occlusion of the coronary artery and downstream causes decreased myocardial performance. Well, this is the pathophysiology of the illness script of a myocardial infarction. And what we want to note is that with a myocardial infarction, management is going to be a percutaneous coronary intervention, door to balloon within 90 minutes. You're also going to try to take care of the thrombus using heparin. Patients who are going to have a myocardial infarction are usually going to be started on dual antiplatelet therapy with aspirin and a ADP receptor blocker. Remember, those are going to be like your clopidogrel, prasugrel, and ticagrelor. And what we want to do is support the myocardium. So you're going to be giving morphine, oxygen. This is going to help with more symptom relief for the patient as well. So let's go ahead and now go into this NBME style question. I'm going to have you answer in the chat box after I read the question. A 55-year-old male with atherosclerotic risk factors, presents with acute chest pain, epigastric pain, and dizziness. He is a smoker. He is noted to be bradycardic and hypotensive with normal pulse oximetry. A right-sided precordial EKG notes ST segment elevation. What is the next best step in management? A, oxygen therapy. B, administration of nitroglycerin. C, initiation of statin. D, crystalloid bolus of normal saline. Or E, TPA. What do you think is the best answer? Excellent. So this patient has atherosclerotic risk factors, including smoking. What is important for us to note is that the patient is bradycardic and hypotensive with right-sided leads, alluding to 2, 3 AVF being dysfunctional, i.e., this is going to be a inferior wall MI. And with inferior wall MIs, what's important for us to know is that you infarcted the diaphragmatic surface of the heart. I kind of like to think of this as the reservoir of the heart. And anytime you get infarction of this, usually it's going to be due to the right coronary artery, you can get a backup of preload. And so when you lose the preload, you want to avoid venodilators. So that's why D is incorrect. And so I like to think of, okay, I'm losing preload, so I need to give preload to push it back up forward into the heart. And so a crystalloid normal saline bolus is going to be your best answer. One of the intentional ways that I wrote this question is I put that the patient is bradycardic. The reason why is because I want to integrate here that the right coronary artery has this very important branch known as the SA or nodal artery. And that nodal artery, if infarcted, can cause you to have bradycardia. So with a myocardial infarction, what I want to integrate here is specifically the inferior wall MI. With the inferior wall MI, you're going to get ST segment elevation in 2, 3, and AVF. With myocardial infarction in general, you're going to be thinking of diagnostics such as an EKG. Note that if the EKG shows ST segment elevations in V1 to V4, then you're thinking of your left anterior descending. If it is going to be in V5 and V6, which is your lateral precordial leads, you're going to be thinking of the left circumflex. And if you're seeing 2, 3, and AVF, that is going to be an inferior wall MI. Other diagnostics for myocardial infarction, you're going to be thinking of getting troponin. This relates to cell injury, death, and adaptation. If you obstruct a coronary, you then are causing decreased perfusion to the myocardium. The enzymes are going to leak out. And so that's why troponin positivity is going to help you stratify a transmural STEMI from something like subendocardial ischemia that you can get from unstable angina. You can also think about getting coronary angiography. And one of the important points here that relates to cell structure and function is if you are going to have an infarct of a coronary vessel, that can actually cause the muscle to be weak. And if the myocardium is going to be super weak, you want to be thinking of getting an echocardiogram. Remember that recurrent MIs or just atherosclerotic risk factors can lead you to have not only myocardial infarctions acutely, but you can end up getting cardiogenic shock as well as congestive heart failure over time. Another very high yield point for us to keep in mind is that if you have a patient with a myocardial infarction, a percutaneous coronary intervention and an angioplasty is going to be indicated for the balloon within 90 minutes. And then you're going to initiate aspirin and ADP receptor blockade immediately. All right, let's go ahead and go through the next portion of this, and this is going through the complications of myocardial infarction. Now, this was a point of kind of confusion for me until I got the timelines down. Just as a big picture before I get into this, whenever you're thinking about the structural changes that may occur, that takes some time, whereas early on, you're going to be thinking of more electricity that gets irritated. So with that big picture overview, let's go into the key vignettes. Let's say a patient with a recent myocardial infarction has sudden circulatory collapse and unresponsiveness en route to the hospital. This is going to be characteristic of a ventricular arrhythmia, something like ventricular fibrillation. Remember that the next best step in management is going to be CPR and defibrillation. Let's say the patient after a myocardial infarction is going to have persistent chest pain, low-grade fever, and a friction rub. You're going to be thinking of pericarditis, and you will see diffuse ST segment elevations as well as PR depressions in patients who have pericarditis. And super early on after MI, if you get pericarditis, it's typically a fibrinous pericarditis. All right, now the structural changes. Let's say you have a patient with myocardial infarction and they have abrupt hypotension, JVD, and barely audible heart sounds, a way that they can describe this as, quote, distant heart sounds. This is going to be free wall rupture, and that free wall rupture led to a tamponade physiology. Remember, tamponade just simply means that the heart, which is going to be denoted here, is going to be filled with or surrounding the pericardial sac in particular, is going to have fluid surrounding it. All right, how about this one? A patient status post MI 5 days ago has abrupt crackles and a new murmur heard at the apex. That new murmur heard at the apex, which is a mitral region, is going to be very characteristic of acute mitral regurgitation, and that is due to the pathophysiologic mechanism of a papillary muscle rupture. Remember, the papillary muscles are going to help anchor down your valves. If you have ischemic papillary muscles, you can get that acute mitral regurgitation. All right, last question on this slide. Worsening, dyspnea, crackles, and an echocardiogram showing myocardial dysfunction with LV dilation. What is the likely heart sound noted? So here you may be paraphrasing that this patient has signs of heart failure, especially with the structural changes showing the fact that the LV is dilated. Whenever you are thinking of the atria filling into a dilated left ventricle, you're going to potentially hear an S3 sound, and that's characteristic for a dilated cardiomyopathy. Remember that S3 is typically known as an S3 gallop. Let's say on the USMLE, they are going to give you a headphone question, making you recognize the S3 gallop. Look at the vignette, and then also the way you can hear an S3 gallop is the fact that it's an early diastolic sound. So you may hear Kentucky, 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 indicating a S3 gallop in the setting of congestive heart failure. Now, you're probably like, oh my gosh, how are you integrating biostats right now? Well, what I want to emphasize here is the sensitivity and specificity concept. Remember, when you have a high sensitivity, you're going to have low false negatives. And if you have a high specificity, you are going to have a low false positive. The point here is that if you are very sensitive, like a screening test, you are not going to characterize patients as falsely negative. You're going to capture a lot of disease. So going through this with something like congestive heart failure, some of the most sensitive findings are going to be dyspnea as well as a BNP elevation. Remember that if BNP is elevated, you could be thinking of some fluid shifts as well as atrial and ventricular stretch. Now, what are more specific for heart failure is going to be the audible S3 that we talked about, as well as orthopnea. And what orthopnea typically is going to be described in your vignettes as is the patient is going to be sleeping with some pillows up, or they're going to have difficulty laying flat. And so they sometimes even call this paroxysmal nocturnal dyspnea. So with heart failure, I wanted to do a little bit of a compare and contrast. On the left, you see reduced ejection fraction, and on the right, you see preserved ejection fraction. This is classically known as heart failure with reduced ejection fraction. It is going to be known as HFrEF, and heart failure with preserved ejection fraction, that's going to be known as HFpEF. So let's go ahead and go through this integration right here. With heart failure with reduced ejection fraction, you're going to be thinking of your classic S3, the JVD, the crackles, and the peripheral edema. Remember that everything is, quote, backing up because your LV is dilated and unable to pump effectively. The management is going to be in acute settings, get the fluid off of the heart. If the patient is unstable, you're going to be thinking of ionotropes like epi. What's important for us to also know is that at times, you may need to reduce the preload, but don't do that if patients are going to be unstable. Additionally, in heart failure with reduced ejection fraction, any agent that is going to modulate the renin, angiotensin, aldosterone system, for example, ACE inhibitors, is going to improve mortality in patients with heart failure with reduced ejection fraction. Now, heart failure with preserved ejection fraction, I like to think of this as diastolic dysfunction. The heart is super thick. You can think of this histologically as concentric hypertrophy. Patients who are going to have heart failure with preserved ejection fraction can have those classic heart failure symptoms, but it's important for us to note the key delineations or risk factors. These patients are going to probably have a history of chronic hypertension. Remember that that is going to cause you to have a chronic afterload state to the left ventricle. The left ventricle is going to get very thick. And whenever you have the atria that is going to be contracting into a very stiff, non-compliant ventricle that's super thick, you're going to be thinking of the S4 heart sound. Now, other causes of this concentric hypertrophy is going to be aortic stenosis. Remember that whenever you have the aortic valve suprastenotic, that's going to cause high afterload to the LV. On your surgery shelf, it's important that if you have a valve area less than 1, you need to move towards repair. Patients who are going to have chronic hypertension and LV wall thickness on the EKG, they can have very elevated QRS complexes, and this is called voltage criteria, alluding to the fact that the QRS complexes are super, super large, and as a result, you may want to be thinking of getting an echo to look at the true thickness of the heart itself. Now, as the name implies, heart failure with preserved ejection fraction, your ejection fraction is going to be normal. And so you're going to be seeing a greater than 55% ejection fraction in your vignette. The management for heart failure with preserved ejection fraction is going to be to treat the underlying cause. For example, control the blood pressure. There could be other causes that are leading to that concentric hypertrophy, things like coronary artery disease, obstructive sleep apnea, which can give you at times cor pulmonale or right heart failure. Things like AFib can also be a complication of heart failure with preserved ejection fraction. Now, what's also important for us to know is that you may want to initiate diuretics. Again, the goal here with diuretic therapy is to make sure that the actin and myosin fibers are going to overlap just the right amount so that then you get really good contractility. So SGLT2 inhibitors have been starting to show some promise here. Remember that the suffix for SGLT2 inhibitors is going to be Flozin. Finally, beta blockers are going to modulate your RAS system. They're going to also decrease myocardial oxygen demand. And so that can be initiated in patients who have heart failure. One very high yield point that I want to make, both for heart failure with reduced ejection fraction and with preserved ejection fraction, is the fact that if you have any structural change to the heart, you can end up getting an arrhythmia. So think about, let's say this represents a wire. If you are going to just really stretch that wire, the actual electricity of those wires may be compromised. And so I always try to keep in mind structural heart changes can lead to arrhythmia changes. And so with that, I'm going to go into how to manage arrhythmias. Before I go into this, is everybody having a good time? Go ahead and type in yes into the chat box. Everybody doing okay? All right, great. Thank you so much for your time and attention. Let's go ahead and hit up the arrhythmias. Now, with arrhythmias, I do want to emphasize that if you see VFib or pulseless VTach, the next best step in management is unsynchronized cardioversion, also known as defibrillation. Remember that these patients are going to have no pulse whatsoever, and you need to characterize these rhythms. Pulseless VTach, for example, is that tombstoning. Now, if the patient is going to be stable and has an arrhythmia, let's say that they have AFib, then you're going to move towards your rate control or rhythm control. So typically, rate control is going to be preferred with beta blockers and calcium channel blockers, but rhythm control with antiarrhythmics is also a strategy. When you see an arrhythmia that is not VFib or not pulseless VTach, let's say unstable atrial fibrillation, you are going to be thinking of synchronized cardioversion. Synchronized cardioversion is going to be used in patients who are unstable with an arrhythmia. What's high yield for us to recognize here is synchronized cardioversion is going to be a form of electrical shock that is going to deliver the shock synced to the QRS complexes. And so that can help you remember that defibrillation is just non-specifically shocking, whereas synchronized cardioversion is for any arrhythmia that is not VFib or pulseless VTach. And in the vignette, the patient is going to be very unstable. They're going to have chest pain, shortness of breath, hypotension, confusion. Their vitals are going to be abnormal. You got to do something now. So sync the shock to the QRS complex. All right, let's go ahead and go through this question. A 60-year-old obese male with history of AFib is experiencing subacute dyspnea. He is controlled on metoprolol, a beta blocker, and apixaban, which is a direct oral anticoagulant. He presents to the emergency room with mild hypotension, continued dyspnea, and decreased mental status. He is found to be in atrial fibrillation. Because he is unstable, he undergoes synchronized cardioversion. What is the next step in long-term management of this patient's arrhythmia? A, plasma metanephrine levels. B, sleep apnea testing. C, spiral CT angiography. D, measurement of ankle brachial indices. Or E, tilt tests. What do you think is the best answer here? So one of the best ways to study shelf and USMLE step 2 material is to have this lens of, quote, treating the underlying cause. If you have that lens of treating the underlying cause, you can then get towards the right answer. In this case, we have to understand, hey, what is triggering this AFib? As you can see, keeps having an exacerbation of it. Well, at times, comorbid conditions, especially in the setting of obesity, such as obstructive sleep apnea, can cause you to have pulmonary hypertension, can cause you to have systemic hypertension, and you are going to need to get a hold of or handle of the obstructive sleep apnea. And so, again, the point of this question is to treat the underlying cause, and that's why B, sleep apnea testing, is going to be the best answer. I do want to emphasize an important point. Patients who are going to have atrial fibrillation need anticoagulation, and that's to prevent thromboembolic phenomena. Remember that this is going to be very classically related to your Virchow triad from step 1. Stasis is going to be the key mechanism because in patients who have AFib, they can have blood that is going to just pool in the atria, and that can then lead to clots. And so we utilize the CHA2DS2-VASc score to stratify what patients are going to get aspirin or a direct oral anticoagulant, also known as a DOAC. All right, so cardio was a little bit of a longer one, but I wanted to spend some time on it as I've gotten some feedback that at times it can be the most challenging. Are you all ready for respiratory? Everybody doing okay? Excellent. Go ahead and type in yes into the chat box. Wonderful. Well, I value your time and attention. Let's go ahead and go through a quick test-taking strategy framework for respiratory. So for respiratory, what I want to emphasize is you must think of respiratory pathologies as either restrictive or obstructive. Restrictive means that you can't get the air in, whereas obstructive is going to allude to the fact that the air is going to be trapped. And as you get questions wrong in respiratory, tie it back to, okay, did I miss it because of a restrictive issue or an obstructive issue? Because I think that going back to a framework is going to help you. For example, things like fibrosis and your pneumoconioses are going to be examples of restrictive disease, whereas things like COPD, asthma, bronchiectasis, those are going to be where you get a lot of air trapping. Chest X-ray will show hyperinflation, and that those are telltale signs along with a low FEV1 of obstructive physiology. So let's say that you have a patient on your USMLE that is going to present with dyspnea. Let's go through some of these vignettes. Sudden onset of dyspnea in a female on chemotherapy with tachycardia and tachypnea. The pulse ox is noted to be low. So in this case, you should be thinking of a pulmonary embolism. Pulmonary embolism is going to be seen in patients who are going to have hypercoagulable states. Remember the classic triad, tachycardia, tachypnea, and hypoxemia. In order to diagnose a patient with a pulmonary embolism, get a spiral CT. And if the patient is stable, you will get imaging and initiate a high IV heparin infusion. Other things that you want to keep in mind, if a patient is unstable, you do not do imaging. If a patient is unstable, for example, if the patient in this vignette has tachycardia, tachypnea, hypoxemia, and let's say I put hypotension, indicating low cardiac output, you're going to be thinking about thrombolytic therapy. Let's go through this next vignette. A patient with dyspnea that is going to be a chronic smoker. You're noticing hyperresonance on physical exam bilaterally. Is this going to be restrictive or obstructive? Go ahead and type that into the chat. Excellent. And if you're saying obstructive, you're absolutely correct. Especially in a chronic smoker, you're going to be thinking of chronic obstructive pulmonary disease or COPD. You do want to really channel in the fact that COPD is going to be bronchitis plus emphysema. Now, the USMLE wants you to know that things like salmeterol and tiotropium are going to be long-acting beta agonists and muscarinic antagonists that are going to help in COPD. But if the patient is already maxed out on those types of medications and is still hypoxemic, then one of the next best steps in management will be home oxygen therapy. All right, let's go through this one. Chronic, progressive, and exertional dyspnea in a female. You note crackles on her physical exam. The patient has normal JVD and decreased total lung capacity, indicating that this is a restrictive pathology. The imaging pattern that you may see here is going to be honeycombing of the lung. And so a high resolution CT can help you diagnose idiopathic pulmonary fibrosis. I do want to emphasize that crackles not only means fluid, but can also mean fibrosis. And that's why I put normal JVD here, because I wanted to shift you away from the concept of heart failure and more towards the fact that this is going to be fibrosis of the lung. Now, pulmonary fibrosis can be idiopathic, or it could be due to secondary rheumatologic causes, such as scleroderma. And it's important for us to note that scleroderma is a pathology in which you can get either focal sclerosis or diffuse systemic sclerosis. All right, continuing on. A patient presents with dyspnea, also noted to be hyperacute in tempo. The patient is altered, tachypnic, has use of accessory muscles. The patient on physical exam has absent air movement of the chest. CO2 is going to be hypercapnic in the setting of the tachypnea. What is the next best step in management? Well, here you have a failure of ventilation, and this is going to be related to critical status asthmaticus, and you may want to intubate the patient. I just want to emphasize here the fact that the patient is tachypnic, but is unable to breathe the CO2 out. So there could be some neuromuscular fatigue component to it. Let's go through this. A patient who has recurrent asthma exacerbations despite use of fluticasone inhaler therapy. The patient is noted to have an elevated IgE level and peripheral eosinophilia. FEV1 is reduced, indicating that it's an obstructive lung disease. What biologic therapy could be considered? And if you are thinking of omalizumab, an anti-IgE monoclonal antibody, you are absolutely correct. Let's go through this last one. Sudden onset of dyspnea in a male with asthma who was eating a granola bar. The patient has GI cramping and exam notes wheezing. As you can see here, this patient has 2 organ system involvement, and there is an identified potential trigger. The patient is here in yellow considered, quote, atopic. Remember, when you see in the past medical history asthma, food allergies, eczema, you should be thinking of an atopic presentation. And these patients who have atopy are at risk at times for anaphylaxis. And so this patient has anaphylaxis. So the next best step in management is going to be intramuscular or IM epinephrine. All right, we're going to go ahead and move into renal. The area that I want to focus on with renal is acute kidney injury. Now, with acute kidney injury, I like to focus on not only what is the trigger, like hypotension or a trigger such as dehydration or IV vancomycin, like a nephrotoxin, but I also go into the labs and I try to look at the BUN to creatinine ratio. Now, with the BUN to creatinine ratio, if it is going to be greater than 20:1, you're going to be thinking of pre-renal. I like to say that you have low effective perfusion to the kidney, and the kidney is sensing that. Intrarenal damage is going to be a BUN to creatinine ratio of 10 to 15:1. And then post-renal, what's important for us to know is initially it looks pre-renal as all of that urine is going to be backing up and going into the aquaporins. But eventually, that's going to be such a cellular stress to the nephron that you will go into more intrarenal damage. So let's go through some key USMLE examples of these conditions. With prerenal, you're going to be thinking of dehydration as well as congestive heart failure. In dehydration, you have low intravascular volume, thus you can effectively perfuse the kidney. In congestive heart failure, you have pump failure at times, and so you can't bring the plasma or blood forward and perfuse the nephron. In this case, patients who have dehydration are going to be hypovolemic on physical exam. So they're going to have dry mucous membranes, delayed capillary refill, whereas patients with congestive heart failure are going to be hypervolemic. So they are going to have freckles, JVD, etc. With intrarenal injury, you're going to be thinking of your classic vignettes, things such as acute tubular necrosis. Watch for the muddy brown cast. Acute tubular necrosis has this phase known as the tubular re-epithelialization phase. This is going to be a patient who initially had acute tubular necrosis and maybe oliguria, but now on the shelf, they say they have liters and liters of urine output. And that just indicates that the nephron is recovering. I also want to integrate some heme-onc here. Tumor lysis syndrome on your USMLE, typically it's going to be a patient that has a very, very high WBC count, let's say in the setting of CML. And when those blasts are going to rupture or open up, they can release a lot of potassium. They can also cause you to have a lot of crystallization within the nephron itself. And so that's why with tumor lysis syndrome, it's not only a cause of intrinsic AKI, but hyperhydration with fluids is going to be an important management step. Remember, hyperhydration is going to be giving IV normal saline fluids at a 2 times maintenance rate. And that's going to be seen in patients with tumor lysis syndrome as well as rhabdomyolysis. Again, it is just to protect the nephron and flush things out. This is an important one that is going to be increasingly seen on your USMLE. This is going to be a patient who maybe took penicillin or, quote, they put in the vignette, treated for some infection, and suddenly has a maculopapular rash and urine that is going to be positive for eosinophils. That is characteristic of acute interstitial nephritis. All right, next one. We're going to be thinking of post-renal injury. And with post-renal injury, it's important for us to think about any obstruction to the genitourinary tract. In particular, if the patient is going to have a renal stone, nephrolithiasis, remember this presents as colicky flank pain that radiates to the groin, or any sort of bladder outlet obstruction. And I would star this. Remember that bladder outlet obstruction is going to be if you have any urethral stricture, all the way to a prostate issue, to even a neurogenic bladder that is not going to have good detrusor contractility to get the urine out. What ends up happening here is if this is the bladder, you're going to get an elevated post-void residual, indicating that there's urinary retention, and you can get bilateral hydronephrosis. And that bilateral hydronephrosis you can see on ultrasound or on imaging. And subsequently, if you have that bilateral hydronephrosis for too long, you can go into an intrarenal AKI. So what's high yield for us to know is that the next best step in management, I'll do in green, you must relieve the bladder or catheterize it in order to get the urine out and prevent the bilateral hydronephrosis. So with that, I'm going to transition and go into some of the rapid review vignettes. Let's say that you have a patient that has acute oliguria, status post a major surgery with increased blood loss. The urine analysis is notable for, quote, brown casts. What will the urine sodium be, high or low? And if you're saying high urine sodium, you're absolutely correct. Remember, this is going to be the illness script of acute tubular necrosis. The trigger was hypotension or hemorrhagic shock. What's important is that the fractional excretion of sodium in intrinsic AKI is going to be greater than 1%. Let's say that you have a patient who has lower abdominal pain, is an elderly patient with long-standing diabetes, who has not seen the physician for 10 years. You notice that the patient has elevated creatinine and a bedside bladder ultrasound noting increased post-void residual of greater than 700 mLs. You're going to be thinking of, you got it, the next best step being relieve the post-renal obstruction, and that is going to be urinary catheterization. All right, let's go through this next one. Heavy proteinuria in a male with history of hepatitis B infection. The biopsy notes thick capillary walls with a spike and dome appearance. Remember that the hepatitis B leading to the proteinuria and the spike and dome, you can be thinking of membranous glomerulonephropathy. I like to be thinking of the spike and dome by using the M in membranous. As you can see, here's the spikes, and you can add the domes on the M. Remember, another mechanism for membranous glomerulonephropathy is going to be antibodies to the phospholipase A2 receptor. Remember, phospholipase A2 is part of the phospholipid bilayer. So it makes sense that if there's antibodies to the podocytes, you're going to get glomerular damage in the setting of membranous glomerulonephropathy. All right, let's go through this. A young female with IV drug use treated for endocarditis. 5 days later, she has a new macular papular rash and elevated urine eosinophils. This is going to be acute interstitial nephritis. The next best step in management is to relieve the drug trigger. Elderly female with long-standing diabetes presents with frothy urine. What class of drugs is going to help slow that progression down? And if you're saying ACE inhibitors, you're absolutely correct. I just want to emphasize this pathophysiology. Remember that in diabetes, you get non-enzymatic glycosylation preferentially of the efferent arteriole. That can cause you to have a lot of mesangial stress in the Kimmelston-Wilstein nodules. That is characteristic of diabetic glomerulonephropathy. And so what you want to do is you want to give ACE inhibitors to relieve the angiotensin II mediated vasoconstriction on the efferent arteriole and reduce the mesangial stress. And so that's why patients who are diabetics that have hypertension or micro or macro albuminuria, you should be considering ACE inhibitors for their drug therapy. All right, let's go ahead and keep going with our review. A patient who has acute flank pain. The patient also has Crohn's disease. The patient is noted to be afebrile, and the UA notes small RBCs in the urine analysis. What do you think is the next step in diagnosis? And if you are thinking of a non-contrast CT of the abdomen and pelvis, you are absolutely correct. This is the classic presentation of nephrolithiasis. I put Crohn's disease here because these patients can get calcium oxalate-based stones due to the malabsorption. I also put afebrile here because I wanted you to differentiate pyelonephritis. Remember, pyelonephritis is fever plus flank pain. If you just have isolated flank pain and it is colicky radiating to the groin with some microscopic hematuria, you should be thinking of a kidney stone. Let's go through this next question. A middle-aged male with history of paroxysmal nocturnal hemoglobinuria presents with acute flank pain and hematuria. He is noted on physical exam to have a bag of worms appearance to the left hemiscrotum, indicating that the fact that the patient may have some varicocele. What is the likely diagnosis here? Well, this patient is going to have renal vein thrombosis. And I want to explain this because it really integrates different organ systems into one. So remember that patients who have paroxysmal nocturnal hemoglobinuria are going to be hypercoagulable. And as they are going to be hypercoagulable, they are going to be at increased risk for clots. So understanding this a little bit more, if this is going to be the renal vein and the patient ended up having a clot, remember that the left gonadal vein is going to drain into the renal vein at a 90-degree angle. So if there is going to be a clot right here in the renal vein, that can cause a back pressure into the gonadal vessels, and that's why you can get that dilation of the pampiniform plexus known as a varicocele. All right, let's go through this. Heavy proteinuria in a male with history of hepatitis B infection. Biopsy shows a spike in dome appearance. I think we did this one already. Sorry, that is going to be membranous glomerulonephropathy. So I apologize. I think I may have just copy forwarded the slide. So thank you so much for your understanding there. All right. One of the highest yield concepts that is going to show up in OB as well as in internal medicine is going to be your conceptualization of incontinence. One of the things that I would do is just draw out the bladder and think about the bladder as a sink, and that can help you integrate these different vignettes. Let's go through these three. Chronic incontinence in an obese female while working out. That is going to be your stress incontinence. They want you to know that that involves increased intra-abdominal pressure causing urethral hypermobility, and that's why you're just leaking out the urine. This is as if you put like a plunger to a sink full of water, and anytime that plunger is going down, that's the increased intra-abdominal pressure, for example, working out, sneezing, coughing, etc. And what's important for us to do is think about pelvic floor exercises. You can also be thinking of a pessary placement, and if that doesn't work, we may consider surgical options. All right, how about this one? A patient who is going to have a chronic intense urge to void. Well, a chronic intense urge to void plus incontinence, you're going to be thinking of urge incontinence. And the way to think about urge incontinence is if this is going to be your bladder and you're thinking of it like a sink, think of it as soon as there's a drop of water in the sink is just going to contract and you're going to release urine. So you want to really relax the bladder. And so you're going to be thinking of antimuscarinic therapy like oxybutynin. Recall that the bladder is going to be under control of a muscarinic receptor. So antimuscarinic can help you relax the detrusor muscle. You can also be thinking of things like mirabegron, which is going to be a beta-3 agonist that is going to help relax the detrusor muscle. All right, how about this one? Acute dribbling of urine in an elderly male with BPH who is now status post Foley removal in the OR after knee replacement. This is going to be characteristic, especially if he has BPH and just got his Foley out. You could get with the neuroaxial anesthesia on board as well. That's that perfect storm of overflow incontinence. And so you want to measure normal post-void residuals. You want to think of cholinergic agonists like pilocarpine, and you may consider in the short-term intermittent catheterization for those patients. So the big picture takeaway here is that incontinence presents as wetting involuntarily. Usually this is going to be in a subacute to chronic tempo. But anytime you have a trauma or some sort of spinal cord pathology and you notice that there is a loss of urine, you should be thinking of a spinal cord emergency or spinal cord compression. This is very classically seen on your USMLE when patients are going to have some sort of malignancy and they have this sudden back pain. And that sudden back pain plus a incontinence symptom, the next best step in management is actually going to be start IV steroid stat, because the spinal cord is under great compression, and you're going to be getting urgent neurosurgical consultation as well. All right, we're going to move towards our next section. We only have a few more high yield sections and organ systems to cover. Before I go any further, we still have 400 people here on the Zoom webinar and those on YouTube. Are you guys doing okay? Thumbs up? Excellent. All right. I'm going to take a little sip of my chai real quick. All right, very good. Thank you all so much. Let's push through. I'm going to move into the chief complaint of abdominal pain. Now, with abdominal pain, let's say that you have a patient who has epigastric pain radiating to the back in a patient with a recent binge drinking episode. In severe cases of this pathology, what electrolyte may be low? And if you're thinking hypocalcemia, you're absolutely correct. I just wanted to emphasize the point of how pancreatitis in severe cases can cause you to have that saponification and the consumption of calcium. Now, what's high yield for us to know is that in acute pancreatitis, management is going to be pain control, hydration. Hydration really is important in order for you to replace a lot of that volume you may be losing, and then a brief NPO status indicating that maybe there could be a signal towards early feeding, improving the pain and overall symptomatology of pancreatitis. Let's say that you have an alcoholic patient who is going to have recurrent hospitalizations for abdominal pain and is now going to present with these, quote, floating stools. What is the mechanism here? Well, this patient who is going to be an alcoholic with, quote, recurrent hospitalizations for abdominal pain, I wanted to allude to chronic pancreatitis. And remember that this goes back to a beautiful basic science tie-in that if you knock out your pancreas, you are not going to have ability to absorb fat as well because your lipases are just going to be completely shot. And so patients with chronic pancreatitis can have steatorrhea, and thus they can have vitamin A, D, E, and K deficiency. What I found very high yield is that the USMLE just loves this concept that vitamin D is going to help protect the bone. So if you have malabsorption, you can get osteomalacia and you can get fractures or weak bone. And then I also like to integrate the basic science here of a patient having secondary diabetes due to the fact that they lost their beta islet cells. And if you don't have good beta islet cells, you don't have good insulin, no good insulin, you can get diabetes. Let's go through this next vignette. An alcoholic male with subacute confusion and physical exam noting diffuse abdominal pain and shifting dullness. So this alcoholic patient with the shifting dullness is going to have probably some ascites. And with these systemic symptoms, such as, for example, confusion and this diffuse abdominal pain, you're going to be thinking of spontaneous bacterial peritonitis. And so you are going to be thinking of getting an abdominal paracentesis. Remember, you are going to see an increased amounts of neutrophils in spontaneous bacterial peritonitis. And you want to get IV antibiotics like ceftriaxone on board. All right. A young female with rheumatoid arthritis who presents with subacute pruritus, you note on your labs there is a direct hyperbilirubinemia and a very high alk phos, indicating that there is some gallbladder pathology with this rheumatoid arthritis patient. And if you're thinking of primary biliary cirrhosis, you're absolutely correct. And with primary biliary cirrhosis, you are going to have positive anti-mitochondrial antibody. Remember, patients with PBC have a chronic autoimmune disorder, usually in their past medical history. And what's going to help with the pruritus and just getting the bile out of the gallbladder tree that is super inflamed is ursodeoxycholic acid. This is going to help with promoting a less toxic bile acid milieu within the gallbladder. All right, finally, we have an older patient with aortic stenosis in their past medical history, has this painless rectal bleeding, and you note a negative colonoscopy. This is going to be a vascular malformation that is typically in the mucosa of the colon, and that is characteristic of, you got it, angiodysplasia. And so sometimes colonoscopy can't pick it up, and so you may need arteriography. Now, I'm going to make like a little bit of a parallel here, just as a fun riddle. Painless GI bleeding is due to, in elderly patients, angiodysplasia or diverticulosis. Painless lower GI bleeding in a toddler, you could be thinking of Meckel's diverticulum. So I just want to emphasize that your painless GI bleedings are things like Meckel's in peds, and then diverticulosis, internal hemorrhoids, as well as angiodysplasia as your internal medicine or family medicine shelves. All right, continuing on. Chronic abdominal pain and right lower quadrant tenderness on physical exam. Malabsorption is confirmed. What is the mechanism here? Well, somebody who is going to have chronic abdominal pain and they may have signs of malabsorption, you're going to be thinking of things like celiac or Crohn's disease. In this case, the right lower quadrant tenderness, I really wanted to emphasize the fact that Crohn's is going to affect anywhere from the mouth to the anus. And so with Crohn's disease, the patients with Crohn's are going to have bile salt malabsorption. And that bile salt malabsorption is going to be in the terminal ileum. So remember, bile salts are going to be reabsorbed in the terminal ileum. Bile salts are important in emulsifying your fats. So if you have terminal ileal inflammation, you don't have good bile salt reabsorption. Because you have poor enterohepatic recirculation, you actually are unable to reabsorb your fats well, and thus you can get malabsorption. What's important for us to know is that whenever anybody has chronic abdominal pain with signs of malabsorption and they are going to have exacerbation of their IBD, you should be thinking of giving IV prednisolone to just calm down the inflammation. And then for inflammatory bowel disease, such as Crohn's, you could be thinking for chronic management to do a biologic like infliximab, which is a TNF alpha inhibitor. I just also want to note that on the USMLE, a very highly tested point is before you start a TNF alpha inhibitor, you do need to do a PPD test to screen for latent TB. All right, let's say you have a patient who is going to have chronic refractory GERD symptoms. They have intermittent diarrhea and weight loss. So after imaging with these red flag GERD symptoms, what do you think you are going to do? Most likely, you are going to do an endoscopy. Now, why do you want to do an endoscopy? Well, GERD with some weight loss or alarm symptoms, that's important for you to actually visualize what may be going on. And let's say that the patient has multiple duodenal ulcers. What I wanted to allude to with the intermittent diarrhea and the refractory GERD, I wanted to allude to gastronoma. And remember, gastronoma can be related to your MEN syndromes as well. Moving on, we have acute unilateral swelling and jaw tenderness in a Sjogren syndrome patient. This is going to be very characteristic of a sialadenitis. The reason why I bring this up is because it is acute in nature. Also, the fact that Sjogren syndrome patients may not have good saliva to keep that duct open, and so stones can form, and you can get that Staph aureus borne parotitis or sialadenitis very easily due to the fact that things are just dry in that area. All right, chronic diarrhea in a med student with anxiety, no red flag symptoms such as no weight loss, normal ESR, negative hydrogen breath test. Why I put that in there is because I wanted to differentiate it from lactose intolerance. The patient has also had a normal endoscopy and colonoscopy. This is kind of like one of the rule out diagnoses. And if you're thinking of irritable bowel syndrome, you're absolutely correct. Remember, IBS is different than IBD. I used to get that confused in medical school. IBS is irritable bowel syndrome. It is going to be either constipation or diarrhea predominant. And remember that they like to say in questions that the pain is going to be relieved with defecation. Usually IBS is going to be an issue with smooth muscle hypersensitivity. I kind of think of this as more of the functional aspects of the GI system being a little bit abnormal. Let's say you have a patient who has non-painful jaundice and weight loss. The patient also has a direct hyperbilirubinemia and a risk factor for this condition with the smoking. You're thinking pancreatic cancer. What is the next best step in management? And that is going to be, yes, you got it, an abdominal CT scan. So remember, this is your classic painless jaundice. And I just want to emphasize the anatomy integration here, that if you have a tumor of the head of the pancreas right here, you can actually obstruct the common bile duct. And that can then cause you to have the direct hyperbilirubinemia. All right, here is our last question for GI. We have a patient who is going to have an NG tube that is inserted. On day 4 of admission, the NG tube output is still large at greater than 300 mLs. What is the likely acid-base abnormality in this patient who may be having a lot of NG tube output, nasogastric tube output? And if you're thinking of hypokalemic, hypochloremic metabolic alkalosis, you're absolutely correct. The way I like to think of this is if you have a nasogastric tube, it's kind of like vomiting where you're just going to be sucking out a lot of hydrochloric acid. And that's why if you're sucking out acid, you're going to get metabolic alkalosis, hypochloremic metabolic alkalosis. And because you are going to be dehydrated or you're going to have probably less plasma volume, RAS is going to kick in and you're going to be wasting your potassium. So whenever you're thinking about a patient who is going to have metabolic alkalosis, let's say it's undifferentiated, what is the next step in diagnosis? And that is actually going to be a measurement of a urinary chloride. Because with a metabolic alkalosis, you want to stratify, hey, is this patient having a low urinary chloride, indicating that this is vomiting or NG tube aspiration? Or does the patient have a metabolic alkalosis with a high urine chloride indicating a diuretic use? Remember that high urine chloride with diuretics, that makes sense because diuretics like furosemide work by inhibiting the sodium potassium 2-chloride transporter at the ascending loop of Henle. And that's why you would have a high urine chloride with a contraction alkalosis. Now, what we're going to be doing in this slide is playing a game called Guess the Chole. So let's go through this. Let's say that you have a stone within the gallbladder. That's going to be known as cholelithiasis. Let's say that you have a stone that is going to get stuck in the cystic duct. That's going to be known as acute cholecystitis, which is the inflammation of the gallbladder. Watch for your right upper quadrant pain, fever, leukocytosis. Let's say that you have a transient back and forth stone obstruction, particularly surrounding fatty meals. That's going to be biliary colic. These patients are going to be afebrile and they're going to have likely at times referred right shoulder pain. Now, let's say that the stone fell into the common bile duct. Well, that is going to be choledocholithiasis. And at times you may need to do a ERCP, which is going to kind of get that common bile duct stone out of there so it doesn't cause upstream inflammation or obstruction. Let's say that the patient is going to have infection of the gallbladder tree. That is going to be your acute cholangitis. That is going to be a patient who has fever, jaundice, right upper quadrant pain. And you could be adding to that schema your hypotension as well as altered mental status, indicating that the patient has acute cholangitis or infection of this. At times, this could be due to choledocholithiasis. So you want to not only do antibiotic therapy, but get that stone out. Remember that the two most common causes of pancreatitis are not only alcohol, but gallstone. And this is where you get the stone that is going to be lodged right at the ampulla of Vater. And then if that stone ended up migrating to the terminal ileum, you can be getting gallstone ileus. And remember, you are going to see at times air within the gallbladder tree as the stone is in the terminal ileum and causing upstream obstruction. So with a lot of these Chole-disorders, I want you to keep in mind that whole female fat 40 thought process, and that's where age sometimes plays a role, as well as BMI and the vital signs. It is going to be for biliary colic in particular, this recurrent right upper quadrant pain. And at times with biliary colic in particular, you're going to be doing an elective laparoscopic cholecystectomy because it's causing the patient's symptoms. What we did notice in many of the vignettes thus far, we noticed that patients have these comorbid diabetes. We talked about that when it came to atherosclerotic risk factors. So in this section of the review, what I'm going to be focusing on is giving you a step 2 vignette related to diabetes and some high yield points. Let's go through this. We have an obese female with type 2 diabetes who has dehydration, serum glucose that is going to be skyrocket greater than 700, and an increased serum osmolarity. This is going to be characteristic of hyperosmolar, non-ketotic hyperglycemia. And in this case, something like an acute illness, like a viral upper respiratory tract infection, maybe corticosteroids, which also can exacerbate your hyperglycemia, or patients who are non-compliant with their diabetic therapy, these patients can end up getting this hyperosmolar non-ketotic hyperglycemia. You stratify this from diabetic ketoacidosis by the fact that the patient is going to have skyrocket high serum glucoses greater than 700. Their anion gap usually is going to be normal, and you're going to be doing IV fluids first as bolus infusions in order to intravascularly replete them, and then you're going to give them insulin to bring down the glucose levels. All right, let's say that now we switch to a chronic tempo and we note that the patient in front of you in your family medicine shelf is going to have a hemoglobin A1C that is going to be greater than 6.5, high blood pressure, high glucose, low HDL, and a increased abdominal circumference. You're going to be thinking, yes, of your metabolic syndrome. Now, with metabolic syndrome, you're going to be thinking of a constellation of symptoms. You want to put them on a weight loss regimen. If they're smoking, remember, smoking is just an atherosclerotic risk factor. So you want to make sure you reduce that from a behavior standpoint. You're going to initiate HMG-CoA reductase inhibition. You could be considering ACE inhibitor or hydrochlorothiazide, especially for the especially if they are going to have hypertension, diabetes, or even their hypertension needs to be controlled a little bit better. And then finally, you are going to be thinking of metformin because that helps you sensitize your insulin receptors a little bit. I also want to emphasize a high yield USMLE question related to metabolic syndrome, and that is if they have AST, ALT elevations that are going to kind of be persistently high over a chronic period of time. This is going to be metabolic syndrome associated liver disease. And this classically was called non-alcoholic fatty liver disease. But I just want to emphasize that this is the liver manifestation of a patient with metabolic syndrome. All right, let's go through this next one. A patient with type 2 diabetes has microalbuminuria in the setting of increased blood pressure. What's the next best step here? And if you're saying initiation of an ACE inhibitor, you're absolutely correct. Remember that getting a urine microalbumin level is going to be superior than a dipstick. A dipstick is sensitive, but it is non-specific. Let's go through this one. Diabetes plus a skin rash. I want to go for a more insulin resistance-based skin rash. And if you're thinking of acanthosis nigricans, you're absolutely correct. Remember, acanthosis nigricans can also be associated with the visceral underlying malignancy. So with that, we're going to pivot and we are going to be going through endocrine. All right, everybody, we're almost done. So let's go ahead and just take a deep breath. I promise you it's going to help. All right, ready? If you haven't done it with me, let's do it again. Come on. Excellent. Let's do it. So with endocrine, I really want to emphasize the feedback loop. Anytime you see an endocrine question, just think about normal feedback, and that will get you closer to the right answer. So let's say we have a patient who has nonspecific nausea and vomiting. She is a young female, has a family history of autoimmune thyroiditis, and tachypnea is noted on your physical exam. What is the next best step in management? Well, this patient with nonspecific symptoms and tachypnea, I'm alluding to Kussmaul breathing, could have a presentation of diabetic ketoacidosis. And what's super easy to assess in this patient is a quick finger stick glucose level. Let's say we have a patient who has chronic fatigue and physical exam that is notable for a drop in systolic blood pressure by greater than 20 upon standing. I want to allude to here orthostasis. The patient also has skin darkening. This is going to be very characteristic of, you got it, Addison's disease. Now, Addison's disease, you don't have good adrenal cortex. If you don't have good adrenal cortex, how are you going to test that hypothesis? Well, you're going to do an ACTH stimulation test. And if the ACTH stimulation test does not increase your cortisol levels and the patient is going to have these symptoms, you're going to be thinking of the diagnosis of Addison's disease. Remember, the skin darkening is due to elevated POMC, and you need to give them back mineralo or glucocorticoids. So that's why you would initiate Fludro or hydrocortisone. Let's go through this one. New onset atrial fibrillation by EKG in a young patient with no history of cardiovascular disease. What is the next best step in management? What do you think? Excellent. If you're saying thyroid function test, you're absolutely correct. Remember, I just want to emphasize here that with new onset AFib, you want to see what is the underlying cause. If there's no history of cardiovascular disease, could this be due to underlying hyperthyroidism? And anytime you see a patient who has primary hyperthyroidism, for example, they have an elevated T4 and a low TSH, again, normal feedback so important, you then want to do a radioactive iodine uptake scan. Because if that radioactive iodine uptake scan is going to show diffuse uptake, you're going to be thinking of Graves' disease as your likely diagnosis. All right, let's go through this one. A patient with lupus on chronic steroids presents with fever, hypotension, and tachycardia. Despite lactated Ringer's fluid boluses, the patient continues to be hypotensive. What is the likely mechanism here? What I want to emphasize with this question is the fact that chronic steroids reduces your hypothalamic pituitary adrenal axis. And this patient comes in with a very severe stress. This is basically the presentation of septic shock. And in the setting of refractory septic shock, and the patient being on chronic steroids and not being able to have that mounted cortisol response, you're going to be thinking of an adrenal crisis, and you want to give hydrocortisone and start norepinephrine, which is going to be a vasoactive that is going to help you in your hypotension with septic shock. So I just want to emphasize the basic science integration here, and that is if you are going to have chronic steroids, that can cause you to have adrenal insufficiency, or essentially your adrenal cortex is going to involute. And so that's why patients on chronic steroids, when they get sick or they go to surgery, they need those stress dose steroids in the form of hydrocortisone. Let's go through this next vignette. Paroxysmal headaches and sweating in a young female. The blood pressure is elevated. Toxicology screen is negative. What is the next best step in management to assess for the paroxysmal headaches and sweating? And if you're saying assessment of urine metanephrines, you're absolutely correct. I put this as a salient pertinent negative because remember, cocaine intoxication can cause you to have the similar presentation, but typically cocaine intoxication is going to be pretty hyperacute. This one is going to be more in that paroxysmal fashion. Why do you want to assess for urinary metanephrines? And that's because your working diagnosis in this patient may be a pheochromocytoma. After thyroid resection in a patient with end-stage medullary cancer due to MEN2, a patient has perioral tingling after the thyroid resection. What electrolyte abnormality may be present? And that perioral tingling, maybe they have some carpopedal spasm. You're going to be thinking of, you got it, hypocalcemia. This is due to sometimes inadvertent parathyroid removal during thyroidectomy. So a few thyroid surgery questions. If they have hoarseness, recurrent laryngeal nerve, if they have electrolyte abnormality, it's hypocalcemia. All right, let's go through this one. We see a patient that has an aldosterone to renin ratio greater than 20. So that means that the numerator is super high. The patient also has chronic muscle weakness. Bilateral adrenal hyperplasia is confirmed. What is the pharmacological intervention? So this patient has the other extreme from Addison's. It's going to be known as Conn syndrome. And in this hyperaldosterone state, you're going to be thinking of giving an aldosterone antagonist like spironolactone. I just want to emphasize that the muscle weakness, remember that these patients with high RAS can be hypokalemic, and that can cause the muscle weakness. And because it's bilateral, unlikely to resect it. And so you're going to be thinking of doing pharmacological therapy. Of note, just to contrast something like renal artery stenosis, remember renal artery stenosis, your renin is going to be very high, and that then is going to trigger your aldosterone. And that is because of the fact that you have low perfusion to the kidney and you're firing off your renin angiotensin aldosterone system. All right, with that, we are going to go into hematology. After hematology, we'll do neuro ID. I have one slide of derm, and then we are going to be done. So if you are ready to lock in, pretend like this is block 6 of your USMLE, go ahead and type in yes into the chat box. Zaina's ready, Ebru, Zane, Purvi, Ria. Excellent. I am so grateful you all are staying dialed in. Remember, focus, focus, focus. It's so important. Let's go through this. Hematology questions, usually patients are going to present with an abnormal CBC. So let's go through each of these. Let's say you have a patient who is a middle-aged male who presents with easy bruising. The patient 1 week ago had a viral upper respiratory prodrome. The CBC isolates a isolated platelet decrease. What is the likely diagnosis? And if you are saying immune thrombocytopenic purpura, also known as ITP, you're absolutely correct. Remember, steroids to reduce those autoantibodies attacking the platelets is going to be first line, followed by IVIG. And in refractory cases, you may have to do splenectomy. So let's say that you have an African-American adult male with sickle cell disease and is poorly compliant with therapy who presents with fever and altered mental status. The patient has no focal neurological deficit. What is the likely diagnosis in this patient? So if they have fever and altered mental status, I'm worried, especially in a patient with sickle cell, of sepsis. And remember, you could be thinking of sepsis due to an encapsulated organism. Remember, patients with sickle cell can be functionally asplenic. I wanted to also emphasize that poorly compliant sickle cell therapy, maybe they're not taking their hydroxyurea. Hydroxyurea, remember, normally is going to help you increase hemoglobin F and is going to be prescribed to patients as the next best step in management when they have recurrent pain crises. Anytime you see fever and altered mental status, you should be thinking of sepsis, especially in a patient predisposed. And why I put no focal neurological deficit is I wanted to rule out a sickle cell stroke. And remember that if the patient did have a focal neurological deficit, next best step in management would be an RBC exchange. All right, let's go through this. A young adult presents with fatigue and pallor. Lymphoblasts are noted. Chest x-ray shows widened mediastinum. What is the likely diagnosis here? And with the widened mediastinum and the lymphoblasts, I'm alluding to TALL. Remember, going back to step one, Pathoma even says a thymic mass in a teenager, think of TALL. It is going to be TDT positive, and because it's a T cell biomarker or CD marker, you're going to be thinking of CD3 positive. So a few things that I wanted to emphasize with this picture is this whole widened mediastinum. If you see that the mediastinum is going to be like greater than 8 centimeters on your clinical x-ray, or for example, it's going to take up a lot of the AP view, you should be thinking of the differential for a widened mediastinum. And this is just a quick radiology integration. Things such as aortic dissection. If I have a female with a chronic cough and erythema nodosum on the lower extremities, hilar fullness or widened mediastinum could be due to that hilar lymphadenopathy, and that's going to be sarcoid. You could also be thinking of myasthenia gravis patient that has a widened mediastinum. That's because of a thymoma that can be associated with patients with myasthenia gravis. I also wanted to emphasize TALL. That could be a cause of a widened mediastinum. But if you have B symptoms, for example, you could be thinking of Hodgkin's lymphoma. And remember, a lot of these mediastinal masses can cause you to compress your superior vena cava. And so you can get facial plethora and upper extremity edema just because of the fact that you have SVC syndrome. And then finally, in this mediastinum picture, I want to emphasize that if I see air here in the mediastinum, you could be thinking of pneumomediastinum. And pneumomediastinum, a few things for us to consider are patients who are going to have recurrent vomiting and Boerhaave syndrome. And you could be thinking of a spontaneous pneumothorax. Again, the fact that there is air tracking in the mediastinum, sometimes that's a big harbinger for mediastinitis. So these patients need stat antibiotics. All right. I did put in a little bit of a PEDS integration. So why don't you go ahead and pause the video and just spend about 1 minute here going through this vignette and tell me what you think is the best answer. I'll see you in a minute. Go ahead and wrap up your answers here. So here you have a patient who has acute promyelocytic leukemia, which is M3 AML. They have sepsis and this characteristic hour rod. One of the things that I just want to emphasize with the myeloperoxidase positive crystal is that that can lead you to DIC. And in disseminated intravascular coagulation, you are going to have issues with primary and secondary hemostasis. So you're going to have a high PTT, a low platelet count, and a high bleeding time. And so I wanted to put that all together in one slide for you. So whenever I think of the CBC, if there is an issue with the hemoglobin hematocrit, you're going to be worried about anemia. If there's an issue with the platelets, you're going to be worried about thrombocytopenia, either quantitative or qualitative, anything primary hemostasis. And then we think of the WBCs. Now, let's say, for example, a patient is going to have easy infections, fatigue, easy bruising. The area that you want to blame whenever 2 or more of these cell lines are down is the bone marrow. And the bone marrow failure could be a telltale sign that there not only could be a viral process like parvovirus, but more importantly, especially if the patient is very symptomatic, you should be thinking of leukemia, an infiltrative process. So with leukemias, they can present as either myelosuppression, so a very low WBC count, or a very high WBC count in the setting of hyperproliferation, increased cell burden. This is where you're thinking of your USMLE questions related to tumor lysis syndrome. So with WBC disorders, they can either be lymphoid in nature, like TALL, which presents as a thymic mass and compressive symptoms. You could also be thinking of multiple myeloma. Remember that these patients are going to be elderly with back pain, hypercalcemia, and those lytic lesions. But the key here is for us to note that multiple myeloma is a bone marrow issue of plasma cells. But the bone marrow failure could be also due to myeloid conditions like AML. We just talked about the acute promyelocytic AML, which presents with the Auer rods and the disseminated intravascular coagulation. What's also important for us to know is that patients who are going to have tumor lysis syndrome, or let's say they're just going to start on chemotherapy for their hyperproliferative leukemia, you do want to be thinking of medications such as xanthine oxidase inhibitors like allopurinol, as well as even rasburicase, which is going to help you conjugate your elevated uric acid. And then finally, you're going to be thinking of CML. And remember, CML is going to be important because CML is a BCR-ABL 922 translocation. That's the Philadelphia chromosome positive. Characteristically, in USMLE questions, if you see elevated basophils in the setting of a very high WBC count, likely it's CML. And then finally, you're going to be thinking of the leukocyte alkaline phosphatase score, which is a marker for normal WBCs. That leukocyte alkaline phosphatase score is going to be negative or low. And that's just because CML, you're just going to be having a lot of leukemia cells that are not normal WBCs. Another cause of bone marrow failure is going to be things like myelofibrosis. And remember, myelofibrosis means that you can get pancytopenia because there's just so much TGF beta that just zaps your bone marrow. And at times on peripheral smear, you can see these dacrocytes, which are those teardrop cells. With that integration, let's go through the remaining portions of heme. So let's say that you have a patient with paroxysmal bouts of dark urine in a young male from Africa who recently immigrated. The CBC is notable for dysmorphic RBCs representing, quote, white cells. What is the next step in diagnosis? Well, if you're thinking of this patient having underlying G6PD, you can actually get a G6PD enzyme analysis for your a confirmatory testing. And remember that the enzyme analysis usually is done after the acute bout of hemolysis. Acute headache, altered mental status, and visual changes in a young female who has a history of chronic pruritus secondary to a JAK2 mutation. This all should be paraphrased as polycythemia vera. So she has altered mental status, visual changes in the setting of polycythemia vera. The acute management is going to be phlebotomy, and that's just because you want to be thinking of polycythemia vera being a condition that makes your blood go from Tabasco to ketchup. And if it's going to be super thick like ketchup, you can get signs of hyperviscosity. And that hyperviscosity can then cause you to clog up your blood vessels, such as the blood vessels perfusing your brain and your eye. The hyperviscosity can cause endothelial injury, and that's why you can get hepatic, vein, or IVC thrombosis, and that's what we call Budd-Chiari syndrome. So what's high yield for us to keep in mind is that patients who are going to have hyperleukocytosis, you want to do urgent phlebotomy and take that blood out. All right, let's go through this one. A young male with easy bruising and bleeding after dental procedures. So this is telling you it's primary hemostasis. The patient has normal platelet count, indicating that it is not a quantitative deficiency. Elevated PTT. What is the diagnosis here? And if you are thinking of von Willebrand factor disease, you are absolutely correct. Remember that von Willebrand factor disease is kind of a mixed primary secondary hemostasis disorder. Your bleeding time will be elevated. Your ristocetin assay is going to be abnormal. And with von Willebrand factor deficiency, if you don't have good von Willebrand, you may not have good factor VIII. And so that's why the PTT is going to be elevated, because low von Willebrand's means low intrinsic clotting cascade activity. And if you don't have good intrinsic clotting cascade activity, you're going to have an elevated PTT. All right, let's move on to our next system. I will tell you, we only have 13 more slides left, so I appreciate everybody's attention, and let's go into neurology. Acute fever and convulsive episodes. After the patient is stabilized, the patient has temporal lobe spikes on EEG. What is the likely diagnosis here? And if you're thinking with the acute fever and temporal lobe issues, yes, you got it. If you're saying HSV, you're absolutely correct. Remember, you want to look at the MRI that will show the temporal lobe enhancement. These patients are going to have a febrile encephalitis, and you're going to be giving IV acyclovir for the HSV encephalitis. Remember, this also integrates to neonatal temperature instability. The 4 most common organisms that we worry about are E. coli, GBS, listeria, and then the 4th one is going to be herpes. Let's go through this next one. Focal neurological deficit, and the patient has increased progressive forgetfulness. The patient has had atherosclerotic risk factors for all her life and multiple episodes for aspiration pneumonia. I want to ask you, from a risk factor standpoint, what is the biggest risk factor for a stroke? And if you're saying hypertension, you are absolutely correct. I just want to emphasize here that whenever you have recurrent strokes, you can get swallowing dysfunction, because now you are going to have at times poor pharyngeal muscle tone. And so patients who are at risk for stroke or who have brain atrophy are at increased risk for aspiration pneumonia. And that's a very high yield pathophysiologic point for you to keep in mind. All right, how about this next one? Activities of daily living decline in an elderly male. The patient has poor recall of items after 5 minutes. MRI shows hydrocephalus ex vacua, indicating that the brain is very atrophic. What class of medications may be helpful in this patient? And if you are saying this patient has Alzheimer's disease, you're absolutely correct. Remember that the issues with balancing checkbook, forgetting to turn off the stove, or getting lost in the parking lot, plus the fact that he is going to have this poor memory decline, you're absolutely correct if you're saying Alzheimer's disease and the use of acetylcholinesterase inhibitors such as donepezil, rivastigmine, galantamine, or even NMDA modulators such as memantine. A young male with incidental finding of Chiari-1 malformation. The patient is noted to have decreased pinprick of bilateral upper extremities, both on the dorsum and ventral aspects of the arm. What is the likely diagnosis? If this was step 1, I would have asked you, what is the likely spinal cord pathway that is going to be affected? And if you are saying that the anterior white commissure and specifically the spinothalamic tract, you would be correct. And this is related to syringomyelia. Remember, this is going to be the cape-like distribution, loss of pain and temperature. The Chiari-1 malformation is usually due to, or is usually associated with syringomyelia, which is a central dilation of the spinal cord. Ptosis and swallowing dysfunction in a male with history of muscle weakness. The electrolyte panel is normal. So you have both bulbar symptoms, which is the cranial nerve 3 and then the 9 and 10, plus this muscle weakness. I can even put that the muscle weakness gets worse with activity. And if you're saying myasthenia gravis, you're absolutely correct. And the confirmatory test is the nicotinic acetylcholine receptor antibodies. Here is a quick HyGuru tie-in. Remember that acetylcholinesterase inhibitors are useful in both Alzheimer's disease as well as myasthenia gravis. For myasthenia gravis, we use things like pyridostigmine. For Alzheimer's, we use the donepezil, ribostigmine, galantamine. We're going to go ahead and wrap up neurology with focusing on headache disorders. Then we have infectious disease, and we are done. Let's go through this. Headache disorders. I want to emphasize the 3 headache disorders: recurrent, throbbing, unilateral headaches with photophobia and no fever indicating that it's not meningitis. That's a migraine. For abortive therapy, you're going to be thinking of NSAIDs and triptans. For more maintenance therapy, topiramate or beta blockers. I want to emphasize this asterisk down here. Medication overuse headaches can be seen in patients with chronic NSAID use. So if somebody has, let's say, even chronic tension headaches, and they're on NSAIDs for a prolonged period of time, you can get downregulation of the inhibitory pain pathways, and subsequently, you can get a rebound headache due to too much NSAID use. Sudden onset periorbital pain at night in a male with lacrimation. And if you're saying cluster headache, you are absolutely correct. The management here is going to be 100% oxygen. A band-like headache in a medical student, sometimes we're subject to this, and that is going to be tension headache. Tension headaches, remember, NSAIDs are going to help, as well as stress relief. And I just want to give you a quick little boost of encouragement that no matter what the score is going to be, don't focus on the outcome. Your NBMEs are going to fluctuate. Just stay positive with categorizing your incorrects, reviewing your incorrects well, and getting better each day. The goal here is to focus on the inputs, not the outputs. All right, cheers. Let's go ahead and go into this next section. Here we go, guys. ID questions. Patients usually present with fever. Usually the tempo is going to be acute. I'm going to go through a few HIV vignettes. A patient who is HIV positive, non-compliant with retroviral therapy, has a CD4 count that is 150, and chest X-ray that notes interstitial infiltrates. What is the infectious etiology that is causing this? And if you're saying this is pneumocystis jirovecii, you're absolutely correct. Remember, patients who are going to have HIV that are going to have a CD4 count less than 200, they should be on trimethoprim sulfamethoxazole, especially if they are going to have confirmed pneumocystis jirovecii infection, pneumocystis jirovecii infection. You're going to be thinking of going to treatment dose of trimethoprim sulfamethoxazole, and if they're hypoxemic, you would add corticosteroids. What's high yield for us to know with pneumocystis jirovecii is that it is the silver stain that you may note on bronchoalveolar lavage. What are the indications for HIV testing in the general population with low risk factors? Again, this sometimes comes up in your family medicine shelves. And if you're saying one-time screening with 4th generation testing in patients over the age of 13 that have low risk factors, you're absolutely correct. And remember that if your combined HIV antigen antibody test is going to be positive, well, then you're worried about HIV because the screening test is positive. So then get a viral load to then go down that management script. All right, let's go through this one. Recurrent painful lip ulcers in a medical student with numbness and tingling prodrome of the upper lip. The physical exam is notable for vesicular blisters. What agent may shorten the duration of an outbreak? And if you're thinking of herpes, which lays latent in the trigeminal ganglia and comes out during times of stress, you're absolutely correct. And acyclovir, which inhibits viral DNA polymerase, may shorten the duration of the outbreak itself. Let's say that you have an obese female with type 2 diabetes who presents with a painful skin lesion recurrent skin lesions that require abscess drainage. On biopsy, you note that the patient has apocrine duct obstruction. What is the likely diagnosis? This is a debilitating infectious inflammatory skin condition known as, yes, hidradenitis suppurativa. Remember that you can get chronic draining tracts or even fistulas with hidradenitis suppurativa. And the pathophys here is an apocrine duct obstruction. And if that is infectious or autoimmune in nature, that can then cause the debilitating recurrence of the skin lesion. Acute, painful, unilateral knee pain in an immunocompromised female on TNF alpha inhibition. The patient is febrile on vitals and unable to bear weight on the knee on physical exam. What is the next best step in management? So I just want to emphasize with this question that if a patient is going to be on a biologic, they are technically immunocompromised. And with fever and a focal joint that is of question, she can't bear weight, maybe there's some fluctuance. Next best step in management is imaging plus arthrocentesis. And you worry about septic joints due to Staph aureus. In this case, for antibiotic therapy after the arthrocentesis, you would consider starting vancomycin to cover MRSA. A patient with acute endocarditis is admitted to the hospital from the emergency department. What diagnostic tests can be useful in confirming the diagnosis with endocarditis? And this is just something that I want to emphasize, and that is that with management, especially if they're like, hey, what's the diagnostic test? Just visualize what's the issue. So if the issue is now I have this bacteria on my valve, how do I visualize that? How do I take a picture of it? Oh, we'll get an echo. And remember that this can at times dislodge and go into the pulmonary or systemic circulation. So get a blood culture as well to look for the staph or strep causing the endocarditis. But I want to emphasize that diagnoses are not going to be best memorized. The management is not going to be best memorized. You got to understand the pathophys. And once you have that rooting why, that I got to take a snapshot of not only the valve, but also what gets dislodged systemically, you will be able to integrate the management reasoning much quicker. All right, go ahead and spend 1 minute on this question and put your answer into the chat box. All right. So this patient is going to have a longstanding smoking history, is now presenting with signs of pneumonia, had a recent community-acquired pneumonia, and finished antibiotics about 2 months ago. You're noticing that we have pneumonia yet again. The patient doesn't have any focal neurological deficits like or past stroke or something like that. And the chest x-ray is abnormal, indicating in the setting of fever that, oh gosh, we are going to have another pneumonia potentially. So in this case, I do want to emphasize that whenever you are going to have a recurrent lung pathology, you should be thinking of getting a CT scan with and without contrast. And why is that? Because you want a more detailed assessment of why is this happening over and over again. And so patients with recurrent infections, not only, especially in peds, do you think of an immunodeficiency, but you can also think of a fixed anatomic obstruction. For example, if this patient ended up having a endobronchial mass, like a lung tumor, and that then is causing a lot of obstruction, now you can get pneumonia downstream. And patients who have recurrent pneumonias, you want to be thinking of, hey, is there a fixed anatomic obstruction that I need to A, get a CT scan, or B, look via bronchoscopy. Patient with pancreatitis admitted to the hospital for acute respiratory distress syndrome, or ARDS, in day 7 has fevers. The CBC notes leukocytosis, and chest x-ray shows this new left-sided opacity. So a ventilated patient with the new lung finding, you should be thinking of, you got it, ventilator-associated pneumonia. So with ventilator-associated pneumonia, the two major bugs you want to cover, this is a hospital-acquired infection, kind of like C. diff at times. Ventilator-associated pneumonia, you want to cover MRSA and Pseudomonas. So that's why you can do like vancomycin and cefepime, vancomycin and ceftazidime, vancomycin and zosyn. But the whole point here is you have to cover these virulent bugs. What is the confirmatory test for an immunocompromised patient who presents with a CT showing an apical cavitary lesion? And what I want to emphasize here is a confirmatory test usually is going to be in the form of a biopsy. So when you see a apical cavitary lesion, you could be thinking of a fungal ball due to aspergillus, and that apical fungal ball can be best confirmed by an open lung biopsy. Remember that patients who are going to have aspergillosis or patients having high IgE levels secondary to the aspergillosis can have allergic bronchopulmonary asthma, and they can present with recurrent bouts of status asthmaticus. All right, let's go through this one. A female with foul-smelling discharge is going to note a vaginal pH of greater than 4.5. The fluid is described as green and frothy with some specks of blood. What is the likely treatment in this patient? And if you're thinking that this is trichomonas, you're absolutely correct. And the treatment here is going to be metronidazole therapy for both the patient as well as the partner. Remember that the green frothy discharge is characteristic of trichomoniasis, and you want to do a wet mount to look at the modal trichomonads. All right, 2 more. Elderly patient with benign prostatic hyperplasia presents with subacute dysuria and frequency, so signs of a UTI. The urine analysis is notable of positive WBCs. What is the next best step in antibiotic therapy? And so I want you to recognize that this is an itis. Itis of what? Likely the prostate. So you want something that has good prostatic penetration, and that is going to be fluoroquinolone. So for prostatitis, signs of a UTI in a patient with BPH, give fluoroquinolone. Young, sexually active female presents with subacute diffuse arthralgias. Patient recently had her menses, and a pustular rash is noted over the dorsum of her toes. You also note that there is pain on manipulation of the joints. So this is a unique presentation. It's systemic because you have this diffuse arthralgias. You notice that there's this pustular rash, and you notice some signs of tenosynovitis. The diagnosis here is disseminated gonococcemia. And this is typically due to Neisseria gonorrhea, and it can be isolated around the time when women have her menses. And the management is going to be IV ceftriaxone. Now, if they put recently had menses and they have systemic symptoms, such as, for example, a maculopapular rash and hypotension, you should be thinking of toxic shock syndrome. Remember that whole retained tampon vignette in which you need source control. You'll treat like septic shock patients with IV bolus fluids of lactated ringers or normal saline, vasoactives. And then because toxic shock syndrome is usually due to staph, you'll cover with vancomycin. And in order to inhibit the TSST1 toxin, at times we do add clindamycin for a bacteriostatic effect. So with that, I just want to emphasize, like, this is exactly how my PEDS, OB, shelf reviews are. I even have a rapid review section in my Step 2 course. And my goal here is to take something like anatomy, and as you can see, I end up putting all of the vignettes associated all on one slide. Now, this takes me a long time because I'm kind of parsing it out, making it easy to remember, making it pretty. But I just want to emphasize that as you go through Step 2 CK prep, take a look at my course that focuses on this vignette-oriented knowledge, because once you even transition your mind into thinking like the test maker, you are going to have better studying efficiency. And I just wanted to highlight that on this slide. All right. So the 4 most common skin rashes that you're going to get. Here we go. Number 1, what is this skin rash? Go ahead and type it into the chat. Yes, it is a waxy stuck-on lesion of seborrheic keratosis. Remember that if you see a patient with seborrheic keratosis, it could actually be normal. How about this one? It's an acute wrestler who has this serpiginous rash with a scaly center. What is the next best step in management? Go ahead and type that into the chat. Good. Topical azoles. Yeah, this is going to be Tinea corporis or ringworm. What about this one? A patient who is going to have a pearly mass on the upper lip in sun-exposed region. They may even say farmer or lifeguard. Yeah, exactly. If you're thinking basal cell carcinoma, you're absolutely correct. And remember, basal cell affects the top lip and is more going to be like pearly and having more of that central ulceration, whereas squamous cell is going to be more scaly and it's going to be on the lower lip. But anytime I see sun-exposed region, I need to be paying my attention to basal cells, squamous cell, and melanoma, your skin cancers. And finally, what if you have a patient with this heliotrope-like rash? This is going to be over the eyes. And if you're saying dermatomyositis, you are absolutely correct. So with dermatomyositis and seborrheic keratosis, remember both of these are associated with visceral malignancy, especially if you get multiple bouts of seborrheic keratosis. You should be thinking of the lesser Trelot sign. And patients with dermatomyositis, they may also have visceral malignancies like GI adenocarcinoma. So I just want to emphasize the tie-ins with the skin lesions. So you are on block 8, question number 12. And what I will tell you is, because you are a cognitive athlete, on block 8, question number 12, similar to how I have not run out of gas, you're not going to run out of gas either. So let's go through a quick antibody review to close this session out. HLA-B27. Think of your seronegative spondyloarthropathies, things like ankylosing spondylitis with the bamboo spine. C-ANCA. Remember, that is going to be related to antiproteinase 3. So you're going to be thinking of your formerly known as Wegener's, your GPA. P-ANCA. That is going to be myeloperoxidase positive. You're going to be thinking of eosinophilic granulomatosis with polyangiitis, formerly known as your Churg-Strauss, microscopic polyangiitis, and then also think of ulcerative colitis and the gallbladder disease, primary sclerosing cholangitis, being P-ANCA. Anti-acetylcholine receptor antibody, that's going to be myasthenia gravis. Anti-basement membrane antibody, that's patients who present with hemoptysis, hematuria, and a linear immunofluorescence. That's going to be your Goodpasture syndrome or anti-GBM disease. Anti-beta-2 glycoprotein. This is going to be lupus with anti-phospholipid syndrome. Remember, anti-beta-2 glycoprotein and lupus go together, and you can have an elevated PTT but still be hypercoagulable. And for your OB shelf, you got to know recurrent abortions, think lupus. Anti-CCP, I kind of do C like this, and that is going to be rheumatoid arthritis, helps me remember the joints. Anti-centromere antibody. This is going to be very characteristic of your focal scleroderma, so your Crest syndrome, calcinosis, the Raynaud's. They love for you to know with Raynaud's, start calcium channel blockers or avoid the triggers because it's that red, white, and blue, kind of like July 4th type of skin rash. Esophageal dysmotility, sclerodactyly, telangiectasias. Remember, it's tight, tight, tight skin with your focal scleroderma. Antidesmosome, that is going to be your pemphigus vulgaris. Remember, you have mucosal involvement. Anti-double-stranded DNA, anti-Smith. Think about house. It's always, quote, lupus. Anti-endomesial. This one is going to be associated with, again, that chronic abdominal pain and malabsorption. Celiac, good. Anti-hemidesmosome. That is going to be very characteristic of not pemphigus vulgaris, but bullous pemphigoid. Remember, those are those taut blisters. Antihistone antibody. Now, watch for the drug trigger. That is going to be drug-induced lupus. So they'll say, hey, I got started on a drug for latent TB, and then boom, I have joint pain, malar rash. That is drug-induced lupus, antihistone antibody. Anti-Jo1, that is going to be polymyositis and dermatomyositis. Remember, those are going to be associated with tRNA synthetase. Antimitochondrial antibody, that is going to be your primary biliary cirrhosis. Remember that your your P-ANCA was going to be associated with PSC, whereas your antimitochondrial antibody is PBC. Anti-topoisomerase, that is going to be your systemic scleroderma. Remember that these patients can even have hypertensive crises because of the sclerosis and the fibrosis of the renal artery shooting up your blood pressure. In your vignettes, your blood pressure will be greater than 180/110. And that's important for us to recognize as a systemic complication of this chronic rheumatologic disease. And then final slide here, anti-smooth muscle and anti-LKM. You're going to be thinking of autoimmune hepatitis. I like to think of the smooth surface of the liver. Watch for your AST, ALT being in the thousands. Anti-Ro and anti-La, that is associated with Sjogren's. Anti-Ro can also be seen in lupus at times, but Sjogren's syndrome is your SSA, SSB antibody. Anti-thyroglobulin, that is going to be very characteristic of Hashimoto's thyroiditis. Remember, that's a cause of hypothyroidism. And anti-presynaptic voltage-gated calcium channels. Think of Lambert-Eaton syndrome. And remember, that's associated with your paraneoplastic syndrome with small cell. So a lot of these rheumatologic conditions have this vasospastic finger disease known as Raynaud's phenomena. This is where in the vignette, they'll say that the fingers turn pale and blue at times. So the next best step in management is treating the underlying cause of the rheumatologic condition. At times, you want to avoid extremes of temperature, like cold, for example, that can trigger it. Calcium channel blockers are going to help with just that little bit of vasodilation. And then because that vasoconstriction and Raynaud's can cause you to have endothelial injury, you can actually get digit ulcers at times. And in those cases, you do need to start aspirin prophylaxis. Real quick, just as a pimp question, if I have a patient who has aspirin overdose, what would be the acid-base abnormality in patients who have aspirin toxicity or overdose? Excellent. If you're saying a mixed respiratory alkalosis and a anion gap metabolic acidosis, you're absolutely correct. Other things is the patients will have tinnitus because these patients are going to have ototoxicity from the salicylate. And the next best step in management is going to be either dialysis, or before that, you're going to be thinking of alkalinization of the urine. So alkalinization of the urine is the right answer for both TCA overdose as well as salicylate overdose. Just wanted to integrate that one because it does show up on exams. Oh my gosh. Question number 39 on block 8 is a chart question. What? All right, guys. I promise this is the last question of the review. Go ahead and spend some time on this chart-based question. I've incorporated these into my new content in my Step 2 course. So feel free to just spend about a minute going through the 72-year-old chart. What do you think is the diagnosis here? Excellent, especially with the ESR and CRP being elevated with the tenderness near the TMJ. You got it. If you're saying temporal giant cell arteritis, you're absolutely correct. Start steroid stat before you do biopsy. And the rheumatologic condition that's associated is a patient who has polymyalgia rheumatica. Remember, they have proximal muscle stiffness. So polymyalgia rheumatica and temporal giant cell arteritis, there's a link there. So I wanted to highlight it. And you want to give steroids to prevent any complications such as vision loss. So with that, I am going to end today's review. I want to just tell you from the bottom of my heart, thank you for spending some time, whether you're watching this live right now or later on. You going through this review is going to empower you not only for your shelf comp CBSE or Step 2 CK, but also is going to help you become a better doctor because that's what it's all about. If you all are interested, I'm going to be putting in my Step 2 course here in the chat box. And if you feel like the Step 2 CK course isn't right for you right now, I understand I have a lot of free content, but this is going to be more comprehensive. It's going to give you the rest of internal medicine and the other shelf clerkships. You can also just spend just a little bit of time following me on social media and telling your friends all about HyGuru. And if you found any value in today's seminar today, just spend 2 minutes writing a review. What did you like about HyGuru? And how can we continue to one med student at a time get this mission of kicking ass on the USMLE and becoming better residents? So feel free to check out my Step 2 course. I'm going to stick around for any questions. And my handle is at HyGuru Prep. You can even type in my name, Rahul Damania, into Google and even ChatGPT now, which is crazy. But feel free to tag me with your study space, the fact that you thumbs up, finish this review, and look forward to connecting with each of you. Before you leave, feel free to just type in, just as a retention, one thing you learned from the review today that really was a great takeaway for you. Think about the session globally. And afterwards, if you don't have any questions, you are free to leave. And thank you so much for your time.